Good morning, good afternoon, everyone. Welcome to the Secure webinar. Today, we'll be focusing on investing in mental health. My name is Vasuntara Yimpriksawan. I'm a Senior Universal Health Coverage Specialist with the Asian Development Bank. Today, we'll be diving into a number of areas of mental health and its importance as part of human and social development. Before we start, we just want to acknowledge that this is part of our ongoing regional technical assistance on strengthening integrated primary health care for non-communicable disease and mental health. In the session today, we would have a different perspective on mental health from global and regional side with the evidence base, including the country case study, which we learned from the Thailand experience and the journey through the mental health policy and programs. After that, we will continue into the panel discussions, learning from academic experience and also insights from civil society and policy advocacy. In terms of house rule, please feel free to put on comments in the chat box, and then we'll be revisiting during the Q&A session. We will first start with a couple of presentations, and then we follow by different aspects of the panel discussion. Without further ado, we will first start with the economic and investment case of mental health. And with this, we have Dr. Rachana Parikh, who is a mental health specialist with PATH in their country program. Dr. Parikh has had a number of extensive experience with national and state government, and also have been working with PATH and ADB teams since the last couple of years on integrating mental health in primary health care, and in particular on the technology and mental health and NCDs. Dr. Rachana, the floor is yours.
Thank you so much, Dr. Vas, for giving my brief introduction. I'm really happy to be here with you today to discuss about why mental health is an important investment case for all our countries in the Asia-Pacific region. When we talk about mental health, we are not really talking of a single condition, but we're looking at a range of conditions spanning common mental disorders like anxiety and depression, to severe mental disorders like schizophrenia, bipolar disorder, neurological conditions like epilepsy, dementia, migraine, strokes, as well as substance use disorders, and self-harm and suicide deaths. So essentially, we are looking at a huge number of conditions that affect a significant proportion of our population. And the main disease burden with respect to mental health comes in from non-fatal burden. These account to a very huge proportion of years lived with disabilities across our countries in the region. Deaths by suicide is also a very important priority in our region. People with severe mental disorders and with other neurological conditions have reduced life expectancy. So you're looking at premature deaths, which are 10 to 20 years before the average life expectancy across countries. And this burden is not just distributed to low-income settings or low-resource countries or low-income countries. It's actually quite distributed across high-income countries as well as low-income countries, making it a priority across our countries. But with countries with much more severe gaps in terms of services, this is a much more urgent priority. It also threatens to constrain our demographic dividend and the progress we've made towards achieving development goals across the region. We've heard of this statement for many years now. Global economic cost of mental disorders is around $1 trillion per year lost in productivity, and with projections to $16 trillion by 2030 if remains untreated and unaddressed. What this really means is that economic impacts are considerable and primarily coming from absenteeism, presenteeism, unemployment, premature mortality, labor force exit, etc. And this is evidenced across countries which have mapped this kind of burden and impacts on their GDPs. However, what this number does not include is how much expenses this is going to account in terms of health system expenditure, informal caregiving costs, educational attainment loss, intergenerational poverty, criminal justice system costs, social protection expenditure, and other intangible losses in terms of suffering. As well as we must also look at the emerging need and the emerging shift in the markets, which also tends to show that the requirement or the need for mental health treatments is growing across countries in the region and across settings. So let's look at where we are with respect to investing in mental health. At this point in time, large proportions of people across countries do not receive care. We're looking at treatment gaps as high as 75 to 80% in a lot of countries across the region. We're looking at severe shortages of human resources across psychiatrists, specialists, across psychologists, as well as other social workers who will support mental health care. We're also looking at chronic underinvestment, which is less than 2% of total health budgets for most of the countries, severely impacting our current capacities to treat these shortages in terms of HR, infrastructure, as well as treatment gaps. Mental health is also important for health security. Widening the lens a little bit, we are living in a time where climate change, pandemics, and emerging diseases are increasingly becoming prominent and impact our daily lives and our countries at large. We're looking at them causing psychological distress as well as increasing pressure on health systems. At the same time, we are countries that are facing a huge burden of untreated mental health conditions. And this already weakens our capacities to respond to these emerging priorities as well. So the key message is simple. Strengthening mental health systems is also essential for preparedness, productivity, and for national stability as a whole. Mental health is therefore also an important development priority because not only is it is an important health system issue or health issue, it also threatens to take back our success on development goals. Improvement in mental health conditions and how we look at the determinants of mental health also tend to improve how our social development goals are, sustainable development goals are achieved, and it also leaves countries stronger. This brings us to the core point. Is there really an investment case for mental health, knowing that it costs a lot of impact in terms of macroeconomics as well as individual and societal impacts? Yes, it is. We've got considerable evidence to say that we get a high return of investment for every dollar invested. Evidence-based interventions increase this kind of return of investment to 4 to 15 per $1 invested. Adolescent programs, when we invest younger, also increases return of investment, considering future healthcare costs that are prevented and also productivity that is sustained. In effect, the scale-up costs for mental health interventions is low, as well as these interventions are mostly aligned with higher benefit to cost ratios. This makes a strong case for considering investment for mental health. So what are the strategic priorities for investment? I've put a few pointers here in your slide to give a flavor of the kind of interventions and the kind of shifts that we will require, starting from policy governance to health system strengthening, to promote mental health service integration within our existing universal health coverage as well as primary healthcare context, to strengthen how mental health care is provided across prevention, promotion, to identification, treatment, and rehabilitation. This, therefore, is not just about introducing a clinical intervention. It's about a whole requirement of systems approach to look at how investments will sit, not just at improving clinical capacities of healthcare providers to provide care, but also alignment of larger health system components and larger macroeconomic components to promote mental health care delivery. In the next few slides, I'm just going to talk about a couple of examples from countries where at-scale implementation has led to sustainable benefits in terms of both clinical outcomes, but also in terms of returns for investment evidence has been included. Let's look at Singapore, for example. Their REACH program, which looks at preventing suicide among young people, through investments in gatekeeper trainings and identifying youth at risk and supporting them through a nationwide helpline and programs, has led to multi-sectoral gains, not just in terms of improving young people's mental well-being, but also improving their retention in schools, their otherwise productivity-related indicators. The same goes for Indonesia through their large program where they aim to provide mental health care treatment in their puskesmas or primary healthcare centers, has provided considerable benefits and evidence is emerging for how maternal depression as well as suicide prevention and other mental health conditions have been addressed effectively with emerging evidence for higher return for investment. The same goes for Bangladesh, which chose to upscale MH-gap modules for training primary healthcare providers to identify and treat mental health conditions. This has also led to multifold increase in case detection rates and gains in terms of workforce participation, a reduction of morbidities have also been demonstrated. So in conclusion, I would like to urge you to think that today we are not making a decision whether to invest or not in mental health. but to look at, can we afford not to invest in mental health today? Because the benefits of investment are not just in terms of reduction in number of people or number of tallies or number of deaths or number of ILDs, but you're actually looking at how it will improve the overall resilience response of the systems and of the communities and contribute to stability of the countries. Once again, I'd like to say the investment will have to be across life course, and some of the major subpopulation groups that we may consider going forward is investment in mental health conditions for early childhood, adolescents and young people, working age adults, as well as older adults, as most of our countries are at the verge of or have already crossed the threshold, and we are becoming an aging society very quickly. There are many system-wide priorities. As mental health has been chronically underfunded, we will have to step up, invest more in establishing the systems that will promote mental health integration. In short, we'll first have to start by building national investment cases that will guide our directions and convince the ministries of finance across countries to promote more investment in mental health. Let me stop here, please. Thank you. Over to you, Dr. Vas.
Thank you very much, Dr. Rachana. We actually intentionally use this as an opening case for us. We wanted to peel the investing mental health in the different layers. And the first one, as a development bank, want to learn is that what it would cost to the government. And in the course of the session, you will see that we would look at different life course perspective, and then also with different stakeholders. So thank you very much for pointing out this overarching framework. The second part, what we wanted to go in next will be on a very vulnerable population subgroup, which is adolescents and youth. We have Sylvia Wong, who is a technical advisor from the UNFPA Asia Pacific Regional Office. Sylvia has been collaborating with us since late last year and on the Education Forum and really talking about this mental health, importance of mental health and youth. Today, Sylvia will also focus on the importance of the sexual and reproductive health and also this link to mental health. Previously, we have led innovation funds and spearheading partnerships work and really supporting women and girls. So look forward to this session and presentation. Sylvia, the floor is yours. Thank you.
Thank you so much. Can you see my screen?
Yes. Good.
Yes? Okay. Great, thank you. So thank you very much, Dr. Vasu, for this invitation. And it's again my pleasure and privilege to join you and speak about the topic that I deeply care about, and that's adolescents and youth, and how their sexual and reproductive health, their mental health efforts, they must go hand in hand, because we know healthier bodies, healthier minds ultimately contribute to healthier futures for all. So I'll take a moment to walk us through why adolescence is important and how it sets the foundation for adulthood. I'll discuss about the intersections between youth sexual and reproductive health and mental health, including through digital spaces, and then also what we know works to support the whole young person through linkages, through integration, through collaboration across sectors, especially health and education, and with stakeholders as well. So, why adolescence? We all remember when we were young. It was such an important, pivotal life stage of first, but it was also a period of rapid growth, body changes, physical, cognitive, socio-emotional changes. But it was a time for also building self-awareness and autonomy, to chase opportunities and to chase independence. And so here, during this period of life, it's a window of opportunity, as we heard from our prior speaker, that when there are program investments in adolescent, their health, but I'll expand as well, their education, their development, social protection, that helps establish positive lifelong behaviors and sets the course for positive adulthood. And we also know that investments during this critical life stage also creates intergenerational benefits and stronger communities. At the same time, adolescence is a period of rapid brain development. The brain is under construction. And so, with the growing independence and autonomy, we might remember that it was a time of vulnerability because, on the one hand, think of our brain having a mismatch where one part of the brain is developing quickly, and that's the limbic system, which is deep in above the brainstem. Think of our brain during adolescence as a car where the limbic system, it's like the gas pedal. It developed quickly. It's moving fast. It drives our reward-seeking behavior, interest in of just seeking rewards, etc. And adolescents at that time feel and act intensely. It controls the emotions, but it's not quite there yet. On the front side of the brain, the mismatch is the prefrontal cortex, and one can think about this as the brake because that controls planning. We think, maybe that's not the best situation to be in. But that doesn't develop until really fully into our mid-20s. So you have this mismatch of wanting to go fast, and that could ultimately create a window of vulnerability where emotions can potentially override decision making and making adolescents more susceptible to challenges and risks related to their mental health and their sexual and reproductive health. I'm going to describe and share about how youth mental health and sexual and reproductive health really are intertwined, and they have common shared vulnerabilities and risks. But the good news is that they're also common shared protective factors. So on the left-hand side of the screen in front of you, you'll see that some of the common ground factors that could make a young person vulnerable: distressed home environments, poverty, violence in the home or in the neighborhood. So that is like a lack of safety and social protection, harmful gender norms, and discrimination and exclusion as well. And ultimately, that impacts the young person's ability to make decisions, to have power, to have agency. The shared protective factors on the right-hand side, we know what works is when a young person is growing up in a supportive environment that's safe, have supportive family relationships, positive peer friendships, socioeconomic security, so they're not economically distressed. And that also, and the importance of within the community, safe schools, quality health services when they want to seek it. And that helps to build one's positive identity and their ability to address issues on their own while they're forming their independence. There are also gender differences, as probably many of you would know. Many of it starts and forms in early adolescence, and that also is related to the brain development that I was speaking to earlier. Girls' risk would be associated with their bodily autonomy and safety, a lot of the sexual and reproductive health concerns. Boys' risk may be associated with harmful masculinities, those norms that are related to peer pressure as well. So this is just to say that there's an opportunity that because there are shared vulnerabilities and risk factors, some of the same solutions that we do to provide that protective environment would go quite a long way. Here, I'd like to just speak to some of the evidence of where we know with the sexual and reproductive health and mental health linkages of behaviors and factors, and that there's a clear link with depression and anxiety, with earlier quote unquote riskier behaviors with sexual and reproductive health, earlier sexual debut, multiple partners. It also goes the other way, where adverse sexual and reproductive health events, such as early unintended pregnancy, experience of early gender-based violence and assault, those can trigger or exacerbate existing challenges with mental health conditions, increasing the risk of depression, anxiety, and social isolation. And for those young girls who become pregnant early, there's significant evidence that they face higher risks of postpartum depression and socioeconomic stress compared to adult women, quite likely also due with stigma and fear as well. I'm going to touch upon what many of us do know about our online lives, not only as adults, but also among young people, and the intersections between mental health, sexual and reproductive health, and technology. We know that the virtual lives or the virtual world could be quite real for all of us, and including for young people, where their lives online and offline are deeply integrated. For many of them, just going up, and for us as well, going about our daily lives, there's really no distinction with digital AI deeply embedded with what we do. In addition, that could create a quite a challenge because misinformation or deepfakes is quite abundant, and it could be difficult to clarify what's right and what's wrong. And those critical thinking skills have yet to be, or still under development with adolescents. The mental health toll, we know that while technology can offer many benefits, we also know that increased screen time is linked with mental health concerns, increased anxiety, and depression. We also see that there are gendered risks for young people, where girls, young women, young people who identify as LGBTQI, when they may be more vulnerable to online risks, seeing unsafe, extreme content not with their consent popping up in their feed forms of what we call technology facilitated gender-based violence. On the other hand, boys, I spoke to that earlier, they could be exposed to harmful masculinities in online communities. And here the algorithms can move them in a certain direction. So the key message is that we know that there's so much happening in this public discourse. And as a community, we have a role to play in really striking a balance of understanding that there's a need for both safe, ethical, and responsible design. This is a non-negotiable. At the same time, how might we build together with young people healthier digital ecosystems and habits so that we amplify together the vital support and benefits that can come through digital engagement? So I'd like to just speak to a bit more on what works, because this is key when we can more effectively tap synergies between the education and health sector. This was referred to from the prior speaker as well. Um, Schools, they can play a critical role as first responders, especially as adolescents spend quite a lot of their time in the school place. And one opportunity that we know can go quite a long way is comprehensive sexuality education. And it's going beyond an anatomy, but teaching real skills for life. It's about communication, mutual respect, empathy, and consent. So when we integrate mental health literacy and digital skills into such programs, we can help foster student resilience, social emotional learning, healthy habits, and other life skills on and offline. I spoke to this earlier about the importance of safe environments, both schools and in the communities. A supportive school climate and community promotes empathy, reduces bullying and stigma, and promotes zero tolerance for violence. And it could go quite a long way as an intervention in of itself for both mental health as well as sexual and reproductive health. And the role of adults in young people's lives in the schools, teachers and other caring adults. They can foster trust. They can notice warning signs. They can encourage students to seek support and facilitate the necessary referrals to care. I spoke to you about the importance of schools. So again, locating schools where, or locating health services where adolescents are is important. So that's an important model, a promising model of integration. And then and then making outside referrals, the importance of health services, health systems that are youth responsive, friendly to youth concerns. And here we know that a continuum of care is important for young people to seek at one place. They could access comprehensive screening. Many of you may know of a tool called HEADS that stands for a counselor, a healthcare provider screening for the health of the adolescent, asking about their education or employment situation, asking about the A for activities. Are they engaged in outside things? D is for drugs, screening for that. Another D is for, another S is for sex and sexuality, and then also safety and security. So we're screening for the whole adolescent. If they're coming in for one issue, you ask about the whole situation for that person and provide that non-judgmental counseling and making the referrals to trauma-informed services. By doing so, that really improves efficiency and maximizes the existing resources that are available. Another key message I'd like to impress is related to this is the integration with safe and healthier digital environments, where we work to design youth-centered digital health tools with safety, security, and privacy, again, at its core, not to replace in-person professional care, but really to complement and supplement when that in-person care is not available, because that could be quite a lifeline for many young people. And finally, I want to bring this together, building off the importance of why we want to invest in this period of life, and especially for girls, because when we bring these different elements together, we're able to show that these investments in health and education can yield multiple benefits. And here I want to share with this recent research that UNFPA conducted with the Burnett Institute, where we conducted economic modeling on the health and economic benefits from investing and scaling up proven interventions that enable girls to avoid early pregnancy and marriages in 5 Southeast Asian countries. So those were the interventions I spoke to earlier. And our modeling showed that with an additional $5 billion to scale up proven health interventions for these girls in 5 Southeast Asian countries, we were able to prevent 1.4 million unintended pregnancies and 1.1 million child marriages by 2030. And if we scale out and continue those investments, we would generate an additional resources as well. So that means that for every $1 invested, we can get an upward $3 to $10 in return. And this has not yet, the model does not include mental health interventions specifically per se, but building off what we've learned from the previous presentation, I believe truly that we would be able to show a very, very high rate of return as well. So in conclusion, let me just say that with supporting adolescents to be strong and resilient in mind, body, and spirit will be beneficial not only for the adolescents, but for their communities and for their countries. So let me stop here. Thank you very much, Bas, and over back to you.
Thank you very much, Sylvia, for this very comprehensive presentation. And for us, it's very important to highlight that the mental health is not only the issue in the health sector, and really it's embedded within education and overall social development. So thank you very much. And this is also a good segue into the next country case study presentation. We will now learn how this global and regional perspective bringing into the project that highlighting adolescents and youth and children. We are very pleased to have our next speaker, Dr. Sadi Jung Sirakunvit, who is currently director of Psychiatric Hospital, Yuva Prasad Vaitayo Tam. But in the past 3 years, Dr. Dusadi really has led the as a director of Bureau of Mental Health Services Administration, and she has really has been promoted and also mentoring a different project, including the psychiatrist project for the GP in the community. So we really look forward to hear on the particular, programs and challenges and lessons from the Thai mental health programs. Dr. Dutsadi, thank you very much, and the floor is yours.
Thank you very much, Dr. Vas, and good afternoon, colleagues and distinguished delegates. It's a privilege for me to share the experiences from Thai mental health program. And yeah, let me start with this framework. The mental health service structure in Thailand is strategically parallel with the WHO pyramid model, in which we would like to emphasize that the universal health coverage will be put in place, and the majority of our people will be learn or will be literated to self-care before supporting with the primary mental health care by the village health volunteers. And we'd like to ensure that every Thai people will mental health problem will be managed or will be treated with within the proper, I mean the appropriate uh, resources, in which that we means that the complex case will be put in place with the mental health service in psychiatric hospitals and university hospitals, and those with less severe mental health problems will be taken in community or general hospitals or in primary health care, in which we're trying to integrate mental health care into all primary care unit in the country, which is around, we have around 6,000 PCU in the country so far. And that's the framework. But for the program itself, we use the life course approach from the WHO. It's the approach to mental health and well-being in Thailand, that we start from pre-marriage until the natal or antenatal, to the preschoolers, to the school-age children and adolescents, in adults and in elderly. Each age group need different or need a specific mental health programs that will tackle their problems, and and some of the programs will promote their mental well-being, depends on the life cycle they entered. I would highlight the preschoolers and school-age children a lot, because 3/4 of people with mental illness show their have their first symptoms appeared before the age of 18. It means that if we promote child adolescent mental well-being effectively, or prevent mental disorders in children and adolescents, it is more effective in preventing adult psychiatric disorders. And I would pick up I will not go into the details of these programs that implemented in the country, but I would pick up a good practice in mental health, in which we can deliver such programs in majority of our population with different age group like this. In early childhood, I will talk about the Thai preschool parenting program, which is a group training for early childhood caregiving skills to enhance IQ and EQ. And for school and for school-age children and adolescents, I would focus on the digital mental health platform, in which we can cover 60% of the students in the country. For working age group, I would focus on this digital platform, the mental health check-in and the DMind, which is the AI in mental health. And in emergency cases, I will talk about the HOPE project, the Helper of Psychiatric Emergency project. Let me talk about this project one by one. The Thai preschool parenting program is the early childhood care in underserved regions. We went into the tribal villages around 7 or 8 years ago, to create a prototype of early childhood care skills training. This is a family group intervention that designed to enhance childhood development and EQ. And we proved that this intervention is 14 times more effective than the conventional system, and we can recover children with delayed development to normal development without referring them to the hospitals. And after we developed the prototype, we expanded within the domain of the National Economic and Social Developmental Board. We launched this project to cover 7,000 families in 54 provinces out of 76 provinces in Thailand. And after that, we expanded into we commit with the cabinet, and we have the cabinet conclusion that we will deliver this intervention to cover 500,000 families within 5 years. And this intervention is not only the effective one, but we prove that it is the implementable program, and it is the affordable program because it costs only let's say $30 but $30 per family. And so far within this year, we can deliver this project to cover around 60,000 at-risk family in tribal villages and remote area in the country. And we expect that we would develop a positive parenting center uh, to cover it in all regions and all provinces in the country to be able to provide these positive parenting or preschool parent effective parenting program to all Thai families. The second initiative is a school health hero. It is a digital platform that we collaborate between the health sector and education sector, and we develop this digital platform so the teachers and mental health professionals can use the same platform and they can link the data between two sectors. We shift the focus of the schools in the past. We trying to train the teachers on child and mental disorders and ask them to screen the children and refer them to the hospital. But finally, we encounter a bottleneck problems because we have only 200 or 300 child psychiatrists for 12 million children. So we do not have, we cannot provide enough service to such big amount of students. So we shift from screening of the disorder in school into training the teachers to monitor 9 significant symptoms of emotional, behavioral, and social problems in the school. And the teachers learn how to modify the child's behavior and how to do a deep or empathic listening to the children. After we launched this capacity building fashion rather than screening fashion, we found that the teachers can take care of half of the students at risk instead of referring 100% of them to the hospitals. So we can cut half of it at the school, and with and the and those who are not improved after the teachers provide some basic mental health care at school, we will be referred to community hospitals and general hospitals uh, in their provinces. So far, we use this system when we covered 3 million of the students out of 5.5 school-age children in the country. And we found that around 10% of them are student at risk. And after the teachers provide basic mental health care at school and refer them to the hospitals, we found that around 70% of them improved and can return to school and spending their normal life and carry on. They can learn and live together with their colleague, their friends in school. And the third initiative is the digital platform. It is the mental health check-in that we launched it in Thai community since 2020. It is a platform that we try to literate Thai people on self-assessment, mental health assessment for themselves. So this platform will, when people enter into this platform, they will run a self-assessment screening for anxiety, depression, suicidal ideation, and burnout. And after that, they will get some information on how to take care of themselves basically. And those who are not improved from reading such information can put on their mobile phone number, and the mental health professionals will call back to provide mental health counseling. And after we launched it in 2020, 5 or 6 years later, we found that we have 6 million users, which is it's equal to averaging 1.1 million users a year. And at-risk group receive mental health support until their recovery for around 83%. And so far, this is the main digital platform that used in the country so far. But not only the mental health check in itself, but we also developed the in-house artificial intelligence for depression screening. We call it D-Mind. It developed by the data that were recorded with the hotline 1323. This hotline is a suicide rescue hotline. So we've got more than 100,000 records of voices and 100,000 records of depressive score. So we can match the depressive score and the voices. And we use this to feed into the AI. So we do the machine learning. They learn from the voices and the depressive score record. And now it is the first AI in Thailand with the accuracy of depression assessment is comparable to that of medical students. Its accuracy rate is 82%. And so far, until January last year, we have more than 300,000 users, and because we plug in this demand into the healthcare application we call Mo Prom. It's a main healthcare application of the country. So we plug in demand into the application. So we've got 300,000 users, and more than half of them had mild degree of depression, and around 10% have a severe depression. And with those severe depression, they can drop the telephone number again. So mental health professionals will call back to provide mental health counseling within 24 hours. With this AI, it helps us to manage the traffic of people with mental health needs, so we can pick up who should receive the care or support first and who can wait for a while, and depends on the severity of the symptoms. And the last one, the last initiatives I would like to share is the Hope Task Force. It's the initiatives that we link between social media influencers, hotline, online rescue, and on-site rescue. So we link with the social media influencers who have more than 1 million followers. So we ask and request for their support and help, so they can be a kind of gateway to receive a message or the case, suicidal case from their followers, who can see that anybody around them have a suicidal warning sign. So they let the influencer know, and the influencer report to the hotline 1323 providers. The psychologist in that hotline will call to provide an online rescue for those with suicidal sign or attempt or signals. If we cannot contact them via mobile phone, we can contact the police. So the police can run into the scene to provide the on-scene rescue for those at risk. And so far, this is a number at October 2024, but so far we can rescue more than 1,000 cases. This initiative shift the pattern of help, because in the past, Thailand can help people with suicidal idea we can help only people with after first suicidal attempt. So we record them that they are a suicidal attempter. So we just follow and prevent the next suicidal attempt. But this is the first time that we can prevent the first attempt with the collaboration of these three partners. And that's some examples from Thailand, and we learn from that initiatives that three key lessons we learned from that initiatives is that the first one is that mental health in all policy. We need to integrate mental health initiatives in different sectors, like social sectors, economic sectors, security sectors. And not only the initiatives, but we need to think about the initiatives that is implementable. They have the potential to implement, to cover majority of the people, not only in the pilot area. So we apply a strict implementation science in all initiatives to ensure that we can expand the initiatives with high quality. And lastly, the in-house digital initiatives. We try to, or we look for international product on digital mental health, like or some AI from international company. But it seems like for the digital initiatives, you need to know the process of mental health care in your own country, and we need the language sensitive digital initiatives that you can use with your people. So it should be these digital platform is um, feasible and possible to use in the country with high digital penetration, or in a country or in high digital penetration area, or with the digital natives group. And that's what we learn, and that's what I like to share. Thank you so much. And may I go send the stage back to you, Dr. West.
Thank you very much, Dr. Dusadi, and it's really comprehensive and very informative for us to actually see this program across a life course. And also the link well also what Sylvia was mentioned before about the digital age and how vulnerable the young population is. And it's also quite interesting to hear that we can actually now prevent and not only be able to follow up when the suicide case already happened. So thank you. And that concludes the first part of the presentation. But the next part would be also quite interesting to actually hear from three main perspectives. I would introduce the three next panelists all together and then pass on to Dr. Rachana for the discussion. So first, from the government perspective, we will have a follow-up from Dr. Burin Sura Arun Samarit. He's currently a director of the Bureau of Mental Health Academic Affairs. Dr. Burin has been really influential in working with different aspects of our community psychiatric services, but also during and post COVID-19. So we hear his perspective from the journey of the Thai mental health programs. Second, we would have from academic perspective, Professor Santosh Jatrana. She's a professor of demography in the Deakin Institute University in Melbourne. Dr. Santosh has extensive experience as a quantitative demographer, but also has worked as a social epidemiologist on a number of topics from aging, rural and remote health and gender, as well as social determinants. Last but not least, we welcome Ive Sunika, and he's a policy and advocacy advisor from United for Global Mental Health and also working here in the Philippines. Ive has been working with us in different aspects and also on NCD and mental health, and especially on promoting for the young people. He's also a youth-led organization as a board chair member of Mental Health PH, and that's really bringing together lived experience, advocacy, and highlighting the financing and evidence. So thank you very much to have all of you three in the panel, but I pass on to Dr. Rachana also for specific panel discussion. Thank you.
Thank you, Dr. Vas. Dr. Buren, over to you, please, for your thoughts on Thailand's experience. And we're really looking forward to also hear from you what has really enabled to put mental health on top of the priority chart for the country, and what could be some of the lessons that we should take home today. Over to you, sir.
Thank you, Dr. Rachana. And may I share some of my slide here, just to give a brief introduction. Yes, I think what I would like to make on this panel is that it's a Thailand's journey of investing in mental health for sustainable development. But in terms of mental integration, what is the key policy decisions that enable mental health to become a national priorities? So I may suggest about actually Thailand has done a lot. The mental health initiatives and investment for some times, but after COVID-19, many things has to change. We still have some infrastructure, which is the main thing that the main success factors. The first thing is that Mental Health Act. Mental Health Act was first implemented in 2008. Actually, the first thing is that to keep the patient, family, and the community safe. At that moment, it focused on the accessibility and the treatment of the patients, and also being aware about the rights of the provider. But on the amendments of the 2019, this is the second edition of the Mental Health Act. They're providing the more and comprehensive for the rights and care for mentally ill patients. But this time, it's not only the mentally ill, but it tended to have some process of 5 dimensions of the covering up of the mental health as a comprehensive pictures, such as the mental health promotion, the prevention control of the mental health threats in terms of the determinants. The third is that the mental health treatment and rehabilitation. But the fifth part that we have actually done in the second edition was protection of patient, caregiver, and social rights. So this one has the second edition has some penalty issues, such as the social media and about the data protection for patients and families. So Mental Health Act has been under the National Mental Health Commission. So everything has to be under this commission. And the National Commission has been ordering and monitoring under the 5 dimensions. And it has been the second step was that the integration to universal health coverage, which is the financial protection for Thai people. So we include the mental health issues in terms of promotion and prevention. We use the screening and mental health assessment. The second thing was the treatment, and also especially we start with the extended service out of the hospital, such as the psychiatric home ward, and also with the hotline. And the third thing is that some innovation has been input for the health, for the financial protection as well. So this one has been the listed of the integration of universal health coverage. Another step is that we try to put the policy and plan in another level, from top to bottom and bottom to top, such as in the department level, we use the theme of the mental health anywhere. This is a policy from the director of the mental health, Department of Mental Health. In number 3, you can see as the ministerial level, we integrate the access of mental health and substance use treatment and care system on this. Alongside with this, in the government level, we push another levels for the Mind Month as the policy advocacy for the cabinets, and the cabinets have been approved that on May of each year has been designed as the Mind Month, which is the month for the awareness for the mind issues and the mental health issues. So to reduce the stigmatization and use as the accessibilities. And what we want the most is from the multi-stakeholders to play a part in the mental health as the relevant theme for mental health anywhere. So in national level, under the National Mental Health Commission, they launched a National Mental Health Action Plan and under approved for the National Mental Health Commission, which is the 20 years plan. So you can see that the Thailand National Mental Health Plan has been implemented for 20 years. And so right now we are going to the second phase. So this vision is that Thai people of our age has wisdom, high emotional intelligence, happiness, and valuable life in society. We have the 4 section of the strategies issues, like the promotion and prevention. We promote the mental health across the lifespan. Mental health service, we develop the equitable access to the mental health services. And social welfare law legislation, facilitate the human rights, laws, regulation, and social movement for the mental health. And academic mental health mechanism, we strengthening the mental health through the evidence-based health economics and policy advocacy. So this one has been pushed under the National Mental Health Plans. And for another, so this has been adopted under the National Mental Health Commissions, which has a lot of people across sectors, not only the health sectors or mental health sectors, but also with the government of the with the private sectors and NGOs has been come together for doing the national mental health plans. So the third step is that decentralized mental health service structure. After implemented into the primary healthcare, you can see that there are a lot of the mental health structures in Thailand. We try to compare with the WHO pyramid models. So this one is Dr. Bisli has been already presented, but I would like to add more of the issues that we try to put it, like the self-care. We use the mental health literacy as the strategic issues for our Department of Mental Health, and the primary health care. We use village health volunteers along with the multi-stakeholder involvement and mental health service in PCU as well. So this one has been going up in the decentralization of the mental health service structures in Thailand. What is the lesson learned for Thailand? Thailand has been recognized in terms of strategic investment for regional impact. I think it's different. It's up to the context and the needs for countries. But what we have learned is that this in-system integration, we should embed the mental health into the primary health care, and the universal health coverage has been played a part on decentralization. The second is that digital leapfrogging. Right now, I think the tendency of the generation, the next generation has been coming up to be an adult. So what we try is that we have to input more of the technology to bridge the specialist gap. Because in Thailand, we have low resources, not much resources of the specialists, such as psychiatrists, psychiatric nurses. We have done it underway, but I think this is a bottleneck. But there are lots of mental health needs increasing after COVID-19, especially people has been more aware, especially the young generation has been more aware about their mental health. And so the building capacity in the community capital, apart from the village health volunteers who has been screened and catch up as a gatekeeper for the community, we need to develop the low-intensity mental health counselor as well. In Thailand, we developed the low-intensity mental health counselors, and we have a standard for and training for the low-intensity mental health counselors for helping them to find a job, and then this is maybe the next job, and bridging the gap into the bottleneck specialists. So this one, I think the impact of evidence that I have seen is that the first thing is an increase on accessibility rates and suicide rates. Right now, we tended to monitor continually for Thailand. The third is that the impact and evidence is that there are more social movement right now and more awareness of people of all generations about their mental health. The stigma tended to be decreased. And the innovation and another solutions from digital mental health screening volume, from the mental health check-in that Dr. Drisili had been said, has been increasing use. And we tended to scaling this up in nationwide. So I think mental health in terms of Thailand is not a choice, but a fundamental right for all. So I think I would like to end my presentation for now. And thank you so much for learning from all of the audience and panelists. Thank you.
Thank you, Dr. Bureen. And that is indeed true for all our countries. Mental health is not just, it's a fundamental right for everyone across the countries. Thank you for that brilliant presentation and for highlighting how long-term vision and supported by legislation, systems integration, along with in-house digital innovations can really leapfrog towards providing mental health care for all. At this point, let me please invite thoughts from our second panelist, Professor Santosh Chatrana. Ma'am, we'd like to know that from your experience and from a research and academic perspective, given that we do need to address mental health urgently, what may be the biggest evidence gaps that you're seeing that needs to be addressed?
Thank you, Rachna. Great question. Let me answer this in two parts. First, broader regional gaps, and then what we see specifically migrants, because this is the area of my research focus. And Oslo, this exposes the fault line is in the whole health system. I think the biggest evidence gap is about not having a nationally representative prevalence data for many conditions and for many populations. So there are three things for the countries, for the subgroups, and for the mental health conditions. In fact, the global audit of data sources used in Global Burden of Disease 2021, it was published in Lancet, and they found that Western Pacific region among the largest data gaps, and also in Asia. And children were the least covered in that. In fact, 90% country globally, they lacked any data on mental health on children, and we know that, from all the presentation, children and adults, and they are the group that are increasingly, facing this issue. And then much of the data on various mental disorders, they were collected before 2010. So we don't have much data. And why this matters? Because without this data, we cannot, and the data, not only the data, but data disaggregated by gender, by age, by subgroups, countries cannot credibly estimate the service needs, cannot set the targets, and cannot evaluate whether reforms are reducing the burden or it's improving the mental health. So this is one. Second one is the biggest the gap is about the effectiveness of coverage. When I say effectiveness, it is not just about that people, they have the contact with the service. It is whether they received timely quality care that improve functioning. So we don't measure that well. So there are many other ones, but I thought that these two are the main one that I will highlight. And when we turn to migrants, these gaps become very sharper. The same thing, but with migrants, we don't have the longitudinal data. We don't model mechanisms that are central to the drivers of migrant mental health. And thirdly, we consider them as a single category, not only the migrants, but we do at the population level, the groups are homogeneous, but it is not. For example, migrants, there are skilled migrants, temporary labor migrants, refugees, women, undocumented workers, and their risk profiles are fundamentally different. So the most data set, they do not disaggregate adequately. And in these countries, Asia Pacific, they are defined by migrants, particularly temporary and undocumented migrants. So the regions defined by migrants, a system set for static population is not going to work, and particularly for mental health. I'll stop here.
Thank you, Professor. Indeed, it highlights. Indeed, you highlighted key points that not only do we not we have understanding of what may work, but we probably don't have enough ways of documenting where the burden is, what the burden is, and how far our services are catering to the burden. I think this is also important for how we make a case for investment at country levels. If we don't know who, how many, and how and what kind of impact our services are doing, we won't be able to document the change, and we also don't make a proper case for increasing investments. Thank you for those comments. Let me please now invite Ivis. Ivis, you come from Philippines and with your vast experience with advocacy community as well as having your own organization. I would really love to know from your end in terms of the experience of Philippines for prioritizing mental health. Give us a little bit brief about that. And also then speak about what helps in sustaining commitments for investment in mental health and how does advocacy and civil society partners can come together to foster this change, to push this change a little more. Over to you.
Thank you, Rachna. Thank you, everyone. Thank you for the opportunity to share my experience. This is a very Thank you very much, Dr. Rachana. I'm Ives. I'm one of the co-founders of Mental PH as well, locally here in the Philippines, and it's actually turning 10 this April. So I've been in the mental health advocacy for a decade now. But one thing that I also want to highlight is that whether you're in the Philippines or in Thailand, from both country level and global work at United for Global Mental Health, three strategies consistently help turn mental health from a conversation into a government priority. Because in the Philippines, through the different works with different sectors, especially young people being also a strong force back in 2018, we were able to actually pass the first mental health legislation. Um, so first is that how can we reframe mental health as not just an economic but also a development investment? So political momentum actually accelerates when mental health is no longer seen as just a health issue, but also somewhat fundamental to both human capital, productivity, and as well as national resilience. So at United for Global Mental Health, the evidence is increasingly clear. I think Dr. Rachan has highlighted this very well that for every dollar invested in mental health services, you can generate around $4 to $5 in economic returns to improve health and productivity. We can take it further when mental health is integrated into existing programs, say for HIV program, the returns are even stronger. Studies show approximately $6 return can be achieved for every dollar, and much more for TB program, it will be $42 in terms of return when integrated, largely through improved treatment, adherence, and recovery outcomes. So these are the kind of numbers that actually shift those conversations from ministries of health into ministries of finance and even development banks. Second is that building coalitions that convert advocacy into an investment and financing decision. So reform happens when, as I said earlier, governments, youth leaders, civil societies, professionals, and multilaterals come to move together. So through our role as secretary to the Global Mental Health Action Network, bringing over now 10,000 members across 170 countries, we help align government, civil societies, and partners to engage major global financing mechanisms. I'm very proud to share one of the clear examples. So we supported countries like Nigeria, South Africa, Pakistan, and the Philippines to integrate mental health into the investment cycles of the Global Fund, which is actually the world's largest financier of HIV and TB programs. From there, we effectively leverage one of the largest multilateral health funding platforms to translate advocacy into sustained national financing and system level reforms. Third and last but not definitely not the least, how can we integrate mental health into existing system reforms? In many low to middle income countries, it's somewhere between less than 1 to 3% of health budgets being allocated to mental health. So progress happens when mental health is embedded into UHC or universal health coverage, primary healthcare strengthening. So I wouldn't want to repeat what all the preceding speakers have already underscored really well, because ultimately it's the government who will actually invest where impact multiplies across different sectors. And that leads to the key lessons we actually see both globally and domestically. Mental health is not something that is a competing factor with development priorities. It actually accelerates them. And if you want resilient economies, productive young population, and even stronger health systems, then definitely investing in mental health is one of the highest returning investment that countries and development banks, as well as different multilateral agencies, can actually make today. Thank you, Dr. Achana.
Thank you, Iris. You once again highlight the fact that mental health is so much intersectoral and not really the domain of only health programming. And the leadership for mental health lies with every one of us who come together to mobilize the data and the change process as well. At this moment, let me come back to Professor Santosh. You alluded earlier to migrants being a specific vulnerable population and suggesting how health for the systems might also have to evolve depending on the kind of vulnerabilities that population subgroups may present. And at this point, let me ask you that beyond health, what key policy drivers do you see are more important or are largely most important at this point for countries to consider for improving mental health outcomes? You might have to unmute your mic, Professor Santosh.
Thank you. Again, a great question. Because when we talk about mental health, by default, we think of health systems, psychiatrists, clinics, or service gaps. But I think the strongest levers for improving mental health, they lie outside the health system, because they are the one which generate those mental health conditions. And some of them were highlighted by the previous speakers. For example, the education system. And the education system is, I think, the largest scalable platform for prevention. And again, it was really highlighted very well in this discussion that the conditions frequently emerge in adolescence. And if we have at the school level, anti-bullying policies, teacher mental health literacy, safe school environment, long-term human capital investment, so they can deal with it. That is one thing. Another one is labor market. Actually, WHO has like the four main outside health sectors, which are the main determinant of health, including mental health. And they are the poverty, housing, education, and employment. So education is very important. Employment is very important. Labor market regulations, enforcement of labor standards, fair recruitment policies, limiting on working hours, same grievance mechanisms, all these interventions. Also social protection policies, because economic insecurity is one of the most powerful predictors of depression and psychological distress. So, there are many policies in many countries, like shock responsive cash transfer, unemployment protection, debt relief, and things like that. And then housing. Last one is housing, because overcrowding, unsafer neighborhood, they really produce chronic stress. So affordable housing, that could also be one of the policy ones. So basically, what I'm saying, we need to work at the systems level. All the things, starting with education, going to the the employment, social protection, housing, all these things. Only then we can improve the mental health. Thank you.
Thank you, Professor Santosh. Indeed, you've highlighted the need for looking at other sectors outside health. At this point, I'd like to come back to Dr. Burin. Based on the very successful implementation in Thailand, especially of integrating with education and maybe other sectors as well, could you highlight what probably were the biggest challenges in scaling up some of these initiatives in Thailand, and how did you overcome those challenges?
Actually, I think although we are somewhat successful, I think I could say that somewhat successful in terms of integrate with other sectors, especially the non-health sectors, for bringing up the mental health issues as a priority, or maybe working together in the multi-sectoral partnership. That's it. Although I think there are many projects that we work together. It's tended to be from the needs too. So we discuss the needs. So that's why we collaborate with needs, and then we can plan with each other. But still, there are some I think some challenges. The first one is that we cannot order them to do. So that's why the how to move them to understand as the mental health as the it's not only in the Department of Mental Health. So this concept is still in many people's it's mental health. It's not other. So we do the other things. So it tended to be some concept like this. So I think rather than that, right now we try to push the policy, and we try to push the concept for the policy level people, as that the mental health is another security issues. It's a national security, because many data show that the investment in mental health can regain the productivities and other things that can be a huge loss as well, especially for the children. So I think this one has to be the concept. The other thing is that the finance if you find the finance from the collaboration in project of Thailand, the finance and the budgets still like a side role. If people from other department has to ask for the budgets, so they allocate the budgets, and then if it's not the roles for the Department of Mental Health, the budget, the national budget allocation is still the problems. So right now we try to push on, move on to the financial from other stakeholders. So we're looking for that in terms of investment and putting some models for and try to think about in the investment benefits so that we can show that after doing some project for some times and reallocating this. And we put this as the into the strategic plan for the next time for the Department of Mental Health to look at it.
Great. Thank you, Dr. Burin, for highlighting these points. And we'll move towards the last question for today's panel discussion. Iris, I'd like to come back to you, especially we've heard multiple times today in the session how youth mental health and investment for mental health for children and adolescents, young adults is a key priority. Looking back at your experience, if you can highlight for us what it is that, given that it's already difficult to bring mental health interventions at scale from within public sector, we also want these interventions to be responsive and reflective of the needs of young people. So reflecting especially on young people, what are the key drivers of keeping these interventions agile and responsive to young people's needs?
Thank you, Dr. Achana. That's a very important question. So if you truly want youth-friendly mental health systems, we need to move beyond consultations and towards more co-creation. So across our work, not just with United for Global Mental Health, but also the Global Mental Health Action Network, one lesson consistently actually comes up. It is where youth engagement works really well when it is institutionalized and not somewhat symbolic or tokenistic in nature. So this means that your youth advisory councils are well embedded within your ministries of health. Lived experience leaders are being recognized and compensated as experts or experts by experience. And young people are meaningfully involved in different processes of the government that includes budgeting, procurement, policy development, and even program implementation evaluation. So I could think of one strong example actually coming here from the Philippines, wherein the World Health Organization Philippines and the Department of Health work together with a civil society organization, which is also my organization, Mental Health PH, to develop what we call a Persons with Lived Experience Leadership module. So it helps to strengthen young lived experience advocates to directly engage government systems, not just at the national level, but even at the grassroots or local level, because the government system here is highly decentralized. So here, people with lived experience act as not just beneficiaries, but as partners in shaping mental health policy and services. So that's one example. Another is that services must be integrated and accessible for young people. Let us be reminded that young people do not live in silos, and so neither should our health systems be. So a young person living with HIV may also experience depression, as already pointed out earlier. A young person affected by climate disasters, a lot of which are a shared reality in Asia Pacific, may actually face trauma, displacement, and even economic stress. So that is why mental health must be integrated again and again into primary care, into different health programs such as HIV/TB program, into sexual and reproductive health services, and across different settings. I will not repeat in terms of the good promising models that have been highlighted by our earlier speakers. But just last point, dignity and trust for young people are considered non-negotiables. So youth-friendly services must be confidential, affordable, culturally responsive, and most of all, stigma-free. So governments must invest not only in the facilities, but also in people, including workforce training, community engagement, and as I said earlier, lived experience leadership. So this is where global and country lessons actually coalesce together and is made clear. Systems become truly responsive when power is actually shared within the communities they actually serve, and that includes young people. Thank you.
Thank you, Iris. That was very, very helpful. I would like to thank all the panel members for this really very enriching and very thoughtful conversation today. Thank you very much for being here and for sharing your thoughts. Let me please hand over to Dr. Vas for the next bits.
Thank you very much, Dr. Rachana, and all the panels. I think it'd be hard to try to summarize all the very rich, perspective I'm discussing here. Before we move into the last part, I would like to introduce our Director of Health Practice, Dr. Eduardo Banzon. And he actually has been a champion of mental health and universal health coverage. I would like to get his perspective, also not only the mental health overall, but how it links with the health systems. So Dr. Banzon has been this last 10 years at ADP, but he has a really rich experience, including as a CEO of the Philippines Health Insurance Corporation, as well as the World and also the World Organization. Dr. Banzon, please.
Thanks, Vas, and thanks to everyone. The presentations, the discussion has very been quite enriching, and clearly, the message that mental health is important for good health, for unhealthy Asia in the Pacific, and that mental health is important in poverty reduction and economic growth was quite emphasized is quite emphasized well, and we in the health team of the ADB and of course ADB in general continue to see that as a very important point that we need to repeatedly talk about. So mental health interventions in mental health is clearly also multi-sector. It's not something that although the health sector should champion this, should lead this, and it should be naturally be doing that. It should not look at it as something that the health sector can solve by itself. Of course, investments in health sector, whether in service delivery, in health sector financing it, in the incorporation of mental health interventions on all type of health services, really the point that was emphasized by our friend from an FPA, is crucial. But we also have to make sure that this is the education sector contributes to this. Our colleagues in urban development should also contribute to this. It should always be part of any climate or disaster response projects. It is something that should always be looked into when we look into workforce, labor, migration, and when we design social protections programs. So clearly, the multi-sector nature of how we should ensure good mental health of the population means that we need to have these multi-sector interventions, which we in the health sector should championing and should be leading. It's also great to hear that there's a lot of very innovative interventions that we're seeing now. And a part of the challenge before, even during my time when I was still in government, was what shall government do? What should be the services that government should be promoting and providing, whether they will provide it themselves or they will finance it, if we talk about health insurance. So it's wonderful to hear Thailand and the way they have actually designed the kind of services. And as this become much more, how do we call it, tangible, much more concrete, then I think it will not be that difficult for us to have discussions with other countries to say, look, these are very concrete operational actions that you could work into. It also means, because for us as development bank, that's also something what we're looking for, on how, in a sense, we could come in and provide additional financing to the budget of government, because in a sense, we are a bank. So that could scale up some of the intervention that was discussed about. It's also great to see how digital tools are now being used. I think I've always say that when we talk about health, we should always include digital as part of the definition of what a health system is, because clearly we should immediately harness all of these digital tools and not leave it as a pilot program or some nice thing to do, but rather have to do in all of that. I think moving forward, we in the ADB and of course VAS will be our lead here, focal. We really work to see how we could incorporate mental health indicators in the different type of projects we have, not just in health, but also in education, social protection, climate projects, urban projects, and others. We will continue to see the type of financing mechanisms that can be explored and developed, how to get governments to pay for it. Everybody talks about health taxes. Are there other way? The private sector, of course, is a big part of the financing of the health sectors in Asia and the Pacific. So we'll try to see how we could actually mobilize the private sector to provide more financing for mental health interventions, and in a sense also for how to mobilize domestic resources. Eves talks about Philippines being heavily decentralized, the devolved setup, and I think this is not uncommon. This is quite common in a lot of other countries, Southeast Asia. So getting local governments to provide that financing, and of course, service delivery can be both from government and private. We should not look at this as simply a government provision, but we should always try to see, and WIN-ADB has always been looking now. This is something of a priority for us to see how we could make the private sector do the services better. In the end, going back to what I said earlier, we see the interventions that will improve mental health, that will respond to mental health issues of the population, as crucial, as important for Asia to become inclusive, to become sustainable, to remain prosperous, and in a sense, protect the gains of poverty reduction that we have seen in Asia for the last 60 years since ADB was started. We see mental health as good economics, as very important to economic growth. And I just want to repeat that over and over again, because I think with that, the more that message gets across, the more that we could have lots of players to support and work on that. So, Vas and everyone in this session, allow me again to congratulate all of you, and yeah, thank you very much.
Very much, Dr. Banzon, and that really wrap it all up. From our journey today, really, we start off the why, the importance of investing in mental health. We talk about and the how and the what, how we can do it, and the program, not only the regional program, but also the country experience. And also you also point out that really what we haven't had here is the private sector, but also the very important role, especially for technology and other financing mechanism. I think one of our last question would be when. And I think the answer is probably yesterday. The investment should have done decades ago, but I think it's never too late. And having all of you today mean that we are not only like-minded, but also we look forward to have this journey together. Working and also collaborating on behalf of the Asian Development Bank. And we look forward to work with different partners, really not only working for the government, but also, as we have today, academic, civil societies, and also the UN and other world organizations as well as a supporter. So with that, I think we will wrap this up. We just all the presentation will be available on the secure webinar page, and also hopefully we can also have this contact also with the speakers. But with that, thank you very much for your time, and also thank you very much to speakers and the panelists to be part of our journey today. Thank you.